We're going to switch gears about the talk. I'd like to thank Dr. Sonnenberg about that very interesting and informative talk. We're going to need to talk about very important subject that we deal with on a daily basis. Most of you guys deal with, like most of you do the PAP titrations. I deal more about like reading those and interpret these PAP titrations. These steps, as you guys do in the sleep lab, are very important to accomplish the goal of having the patient sleep well on a good titration or good CPAP or positive airway pressure. I have no conflict of interest. Sleep apnea, as you all know, is a sleep disorder that causing apneas, hypopneas related to repetitive airway collapse during sleep. Muscle relaxes and you have airway collapse, patient wakes up, causes like a sleep disturbances and abnormal sleep. That causes like a day fatigue and sleepiness and causes like major events in the life too. After diagnosis of sleep apnea, the current standard of practice is to get the patient to the sleep lab and do a PAP titration, get him a best pressure possible to improve the obstructive events. The initiation of PAP titrations involves selecting the mode of the positive airway pressure and titrate the positive airway pressure to achieve the goal of resolve the obstructive respiration during sleep. When we talk about the basics of the PAP titrations, we have to mention the guidelines that were published in the Journal of Clinical Sleep Medicine back in 2008, and is still valid, is still paved the way for us to perform successful PAP titration studies. And these clinical guidelines were like done and performed by American Academy of Sleep Medicine through their panel of directors. So the American Academy of Sleep Medicine level of recommendations indicated in the parentheses next to the level of recommendations. These recommendations were based on the published data. There are some data that what we call expert opinions or consensus, they will marked as consensus after the recommendations is done. Generally and basically we have two major positive airway pressure modes that we mostly deal with and titrate to achieve the goal of splinting the airway during sleep. These are CPAP or continuous positive airway pressure, or BiPAP in spontaneous mode. That means a machine that provides two pressures, one during the inspiration, one during the expirations to provide the same goal. There are more technologically advanced PAP devices designed for different sleep disorders. These are BiPAP, but this time it would be like BiPAP ST or BiPAP in spontaneous time mode and BiPAP T or BiPAP in timed mode. These are different machines that used more for like central sleep apneas or treatment emergent central sleep apneas with a backup rate, we call it. So if the patient doesn't breathe, the machine will give the breath for the patient after a certain time that we set up for. Adaptive servo ventilation is a different machine that also a smart machine that used to treat patients with central sleep apneas or treatment emergent central sleep apneas. It can be used also for like what we call central sleep apneas with chain stocks breathing for patients who they have a congestive heart failure, but there's a certain level of the ejection fractions are lower than that level, we cannot use them. The other machines that can be used for certain other applications is the volume assured pressure support machines, IVAPs or AVAPs. These machines ensure that we have a certain or a good ventilation modes to ventilate the patient. This is mostly used for patients with chronic hypercapnic respiratory failure to make sure that our patient gets the volume needed to ventilate and wash out the carbon dioxide. So when we have patients in our sleep lab, we have goals for the patient. So when you start your patients on PAP titrations, you know your goal to know how to help the patients. And the goal of any titration study is to determine the minimal pressure needed, required to resolve all apneas, hypopnea, snoring, and arousals related to obstructive events in all stages of sleep and all sleep positions. So the key words is minimum pressure needed in all stages of sleep and different sleep positions, like supine positions, lateral position, or even prone positions. So we're going to talk a little bit about the recommendations from the American Academy of Sleep Medicine. So the recommended minimum starting CPAP for adult and pediatric patients are 4 centimeter of water pressure. So when you get your patient to the sleep lab, that's you want to know your limit of CPAP uses. So the minimum you start is 4, not less than that. You could start higher than that based on the patient BMI. If the patient have like a discomfort of that, or if the patient have a severe sleep apnea, so you think you might need more, you don't have much time like in a split night study, but the minimum that you should start is 4 centimeter of water. This should increase gradually up, and your goal again to eliminate the obstructive events for sleep, to eliminate apneas, hypopneas, respiratory event-related arousals, or snoring. And the recommended maximum CPAP levels is 15 for patients who are younger than 12 years old, and 20 for adult patients. So minimum is 4, maximum is 15 for children, or for pediatric patients, maximum is 20 for the adult patients. Then what you do, you increase the patient's CPAP gradually, not less than 5 minutes, and this is very important because if you do keep switching the pressures like every 1 minute, 2 minutes, you will ruin the titration because, for example, if you have like one event in 1 minute, that means a HHI or RDI of 60, even if that pressure might be reasonably okay. So don't try to change your pressure for less than 5 minutes. You go up gradually until you eliminate what you see. So this is the indications of how you change your CPAP. So you increase your CPAP for at least 1 obstructive sleep apnea. So if you have a child or pediatric patient or less than 12 years old, you change your CPAP up for minimum of 1. You can do more than 1 for severe apneas, but 1 centimeter of water, usually in children, will be 1 up to eliminate the obstructive events. So if you see 1 obstructive apneas, you change your CPAP a little bit up. For adult patients, you need 2 obstructive apneas to change your CPAP up. If you see 1 hypopneas for children less than 12 years old, you increase your CPAP up. Remember, not less than 5 minutes, so give it a few minutes. Change you see hypopneas, you go up on your CPAP. You need 3 arousals, so 3 respiratory events related arousals for children to increase your CPAP up. You need 5 RERAs, or respiratory effort related arousals, to increase your CPAP up by at least a point. Then if you eliminate the obstructive events and you end up with snoring, that there's a still indication to go up in your CPAP. So if you see after 1 minute of loud or unambiguous snoring for children who are less than 12 years, you still require that you need to increase your CPAP at 1 point. Usually for snoring, you don't need that much of change. For adults, you need 3 minutes of loud snoring to increase your CPAP. There is something called exploration of CPAP, which is after you eliminate your respiratory events or obstructive events. There are like some data saying that still, even after you initially eliminate the respiratory events, you still have a high resistance in the upper airways and the nasal passages. So you try to explore if higher CPAP than what you achieved will cause your patient to sleep better. So you can explore your CPAP up. So you got your eliminated, you eliminate your apneas, hypopneas, and snoring. You're still allowed to go up a little bit, see if the patient will sleep better with that, but don't go up more than 5 centimeters of water pressure on that. Of course, if your patient wakes up in the middle of the titration and he feels uncomfortable or he feels like the pressure is too high, you should go down to the pressure where the patient feels okay, so he could sleep and you could finish your titration. There's something called down titration as well. So remember, we need to find out the minimum pressure needed. So sometimes going down in the pressure, that will allow us to to find out or to find the minimum pressure needed to eliminate the patient respiratory events. Going down in the titration, so for example, if you achieve your goal by CPAP of 10, you can try to slowly go down every 10 minutes or so until your respiratory events start to appear. Then you know exactly where's your pressure needed or the minimum pressure needed to eliminate the obstructive events. The titration algorithm for the split night for those who want to know, or the split night means the sleep study that has the first part diagnostic, then the second part we do the CPAP titrations. The algorithm for that should be pretty much simple to or the same like the CPAP titration studies as possible. Maybe you need to go faster because of shorter time on the CPAP titrations. This is just a map, or you can bring this and put it in front of you so it will remind us all the time how we do the CPAP titrations. So here is like the minimum start for children is 4 centimeters of water pressure. And again, remember 5 minutes at least to switch your pressure support or CPAP. For children, you need 1 obstructive apneas to change your CPAP pressure. To go up on the pressure, you need 1 hypopneas because AHI in children in general is a diagnosis comes after when you have AHI of like or RDI of 1 per hour. So 1 obstructive apnea is that your patients still have significant sleep apnea. So you change with 1 obstructive apnea for children, 1 hypopneas. If you have 3 arousals or 3 respiratory arousals, you should change your CPAP up to. And if you still have some snoring, even 1 minute of loud snoring, you still go up. And you do this gradually up and stepwise until you eliminate all of your respiratory events during sleep. And you continue for 30 minutes, and you think about, so either you eliminate your respiratory events, or you reach the maximum pressure allowed to use for those patients. Because after that, pressure on 15 centimeters of water for children, and 20 centimeters of water for adults, then we start thinking about the birth trauma and the pressure-induced injuries to the airways and to the lungs after that. So we have to, so if we get to the 15 centimeters of children, then we think about different mode of ventilation. We're starting BiPAP. If we get like a 20 centimeter of water pressure for adults, we think about changing to BiPAP. The same for adults, we do the same thing, and we start with, you can start with 4. Sometimes if you have severe sleep apneas and you think your patient would need more in faster way, you can start higher than that. Just be careful if your patients start complaining about the high pressure or discomfort from that. So start at minimum 4 centimeters of water for adults, and you increase your pressure gradually for minimum of 1 centimeter of water until you eliminate your respiratory events. You need to switch or increase your pressure support for the patient or CPAP intensity if you see a little bit higher numbers of events in adults. So you need 2 obstructive apneas, 3 hypopneas, or 5 respiratory arousals before you change your CPAP. So don't be like, again, changing CPAP too fast, too often will cause us to have a problem finding the best pressure when we read the sleep studies, because the AHI calculated will be really high given the time. If your patient is still snoring, you can still switch go up on the CPAP, and then the snoring is eliminated, even if your other respiratory events are eliminated. Again, if you get to the point that that the patient's respiratory events, obstructive events are eliminated, you can keep your patients like for 30 minutes, preferably on supine position if possible. And after 30 minutes, you can try to explore the CPAP up and see if your patient sleeps better, especially if there's microarousals in the study. You can go up, but don't go up more than 5 centimeters of water, and this is a consensus from our expert opinion about that. Again, you can go down, and our down titration is also allowed. You don't have to do that, but you could do that to find the minimum pressure needed to eliminate the pressures. So what do you do if you get to the maximum pressure allowed or maximum pressure recommended and your patient still have sleep apneas? So if the patient, then you think about starting BiPAP. So we have basically 2 indications to start patients on BiPAP or to start the BiPAP from CPAP. So if your patients is uncomfortable or intolerant of the CPAP, even before you reach the maximum level, some patients, I mean, at 12 or 13 centimeter of water pressure, they will tell you that they can't do this anymore. You could try them on BiPAP. So you try BiPAP. The other indication is if you reach to the maximum CPAP recommended, and your patient, and you still see like obstructive events. Here they said even if you get to the 15, which is kind of a 15 is the max in children, but still if you get to the 15 and your patient is still having obstructive events, you can change to BiPAP. And again, the BiPAP should be increased to eliminate the respiratory events gradually up. So we know our limitations for BiPAP, so we have the indication to start BiPAP. Either our patient was intolerant or have like problems with the high pressure of the CPAP, or if our patients, or if we reach to the high level of CPAP and we're still seeing obstructive events, then we change the patient to BiPAP S, BiPAP spontaneous mode. So the recommended starting BiPAP is 8/4. IPAP of 8 centimeter of water pressure and EPAP of 4 centimeter of water pressure. The recommended maximum IPAP for children who are less than 12 years old is 20 centimeter of water pressure. For adults, you can go up to 30 centimeter of water pressure. I mean, the way to put like, there's like insufficient data to put like how high low to start, but this is the minimum. I mean, minimally you start 8/4. You can do higher for patients who have severe obstructive sleep apnea. So you do higher. So if you titrate patients to CPAP, see for example, you reach the CPAP of 14, and you still see that there is a snoring, there's obstructive apnea. So you don't want to go back to 8/4. You should go with EPAP closer to that CPAP, because you know already that they tried 14 and the patient still. So you're going to waste some time starting lower. You should start a little bit higher, because you know that's what the patient is going to likely need. The difference or the delta pressure between the IPAP and EPAP, minimum recommended is 4 centimeter of water, maximum is 10 centimeter of water. So just be like know that this pressure, the delta or the pressure difference helps the patient ventilate, also can cause the patient to have central sleep apneas or pressure treatment emergent central sleep apneas or complex sleep apneas that we're going to talk about later. So the higher the delta pressure, the more likely your patient is going to have that. So if you have patients who start having centrals after eliminating of the respiratory events, think about the delta pressure, think about how high your pressure is. If you can come down some, these can help. So again, your IPAP or EPAP should increase gradually, minimally by 1 centimeter of water pressure. When you have, again, not less than 5 minutes for the same reason, we need to have a good titration. IPAP and EPAP should be increased because for obstructive apneas, EPAP helps with that. So if you wanna, if the patient showed like one of children or patients less than 12 years old showed obstructive apneas, you wanna increase the EPAP. But remember, you have a delta pressure of 4. So if you have IPAP 8/4 or the difference is 4, you can't just increase the EPAP. You have to increase them both. So you're gonna go IPAP, EPAP increase for obstructive apnea. One obstructive apneas for children less than 12. You need, again, 2 obstructive apneas to change your BiPAP pressure for adults or for patients who are older than 12 years old or older. If you have hypopneas, then you don't have to increase the EPAP, you just increase the IPAP. But remember, the maximum difference will be 10. If you reach to the difference between IPAP and EPAP of 10, then in that case you increase the EPAP, so you keep that maximum recommended range of 10. We do more than that range in other cases like a chronic hypercapnic respiratory failure. But for patients who are just having apneas, hypopneas, you increase for obstructive apneas, you increase the EPAP, but you have to increase them both. If you have minimum difference for patients who have hypopneas, you increase your IPAP, but you have the limit of the pressure difference of 10. So if you get to the 10, then you have to increase your EPAP with that. So indications again: 1 obstructive apneas for children, 2 obstructive apneas for or for patients who are older than, you have 1 hypopneas for children, but 3 hypopneas for patients who are older than 12 years old. Patients who have RERAs, you need at least 3 RERAs, or respiratory effort-related arousals, to change your PAP pressure. You need 5 of those in adults or children who are older than 12 years old. If you eliminate obstructive events and you still have snoring, you're still going to need to increase the IPAP pressure for 1 minute of loud snoring for children. You need 3 minutes of snoring to increase your IPAP pressure. You could explore your IPAP again and see if your patients will sleep better that way, because again, they noted that there's like some increased resistance of the airway, of the upper airways, even after eliminating the pressures. So, but don't do more than 5 centimeters of water of that. If your patient wakes up and he's complaining of a high pressure or was uncomfortable sleeping with the higher pressure you reach to, you can go down on the pressure until your patient is comfortable enough to go back to sleep. You could go, there's a PAP. If you start having like a significant treatment emergent sleep apneas, you can use the PAP in ST mode. We'll talk about treatment emergent sleep apneas in a little bit. Down titration is not something that you need to do, but you could do it to achieve your goal of finding the minimum pressure needed to eliminate the respiratory events. Then the algorithm for the split night PAP titration should be the same, like the PAP titration studies. If possible, maybe you need to go with the higher levels, or maybe you need to switch your pressures more than just one because of the short time in split night sleep study. This is also from the guidelines, and you can print this and put it in front of you. This will help. So for patients less than 12, you start with the PAP. The minimum starting for any patients, for children or for adults patients, is 8/4 centimeter of water pressure. You go gradually up when you see obstructive events. You need one obstructive apneas for children, 1 hypopneas, 3 RERAs, and you need 1 minute of snoring. Whenever you see any of these, you can go up after 5 minutes with your BiPAP. You can go up by 1 on each. You can go up by more than that until you achieve the goal of eliminating the obstructive events. The same for adults. You start at 8/4, maybe higher than that. Again, if you're switching BiPAP from CPAP at higher level, you don't go back to 8/4. You go back close to your EPAP. So EPAP should be close to your CPAP. So if you get so if you're at CPAP of 15, and during the CPAP titration or PAP titration study, you don't go back to 8/4 because you're going to just waste some time. You go back higher. I would go to like 16/12 or 17/13 or something like that, closer to where the patient CPAP was, and try gradually go up. If you reach to sometimes you reach to the maximum BiPAP and still patient have sleep apnea, you may try other things. Try to turn your patient to the left side, try to do other things, try to make sure all the time that your mask is well fit, and we'll go from there. We reach to some patients, they still you're going to have significant leftover sleep apneas even with maximum. Then other things will be indicated. So after you're doing all of this, what's the acceptable PAP titration study? How can you say that your PAP titration study was successful or not? The pressure selected for patient following the titration study should reflect control of the patient obstructive respiration. And how do you know about that? You should have a low RDI. This is not AHI. This is RDI, respiratory disturbance index, which involves the apneas, hypopneas, and arousals as well. You should have a good oxygen saturation at all times, should be at least 90% or higher, and the leak should be acceptable as well. So you have acceptable leak, you have a low respiratory events or eliminated, and you have a good oxygenation. American Academy of Sleep Medicine also put like this grading system for the PAP titration studies. So you have an optimal titration if you're able to eliminate the patient's RDI or reduce the patient's RDI less than 5 per hour for at least 15 minutes. This should include supine REM sleep at the selected pressure. This should not continue interrupted by spontaneous arousals or awakening. This is consistent with optimal titration, which is the best. Good titration, you were able to eliminate your patient's respiratory events or having like an RDI of less or equal to 10 per hour, or reduce your patient's respiratory event by 50% if the RDI, baseline RDI was like less than 15, because it's automatically like it will be less than 10. And this should include the supine REM that's not continually interrupted by spontaneous arousals or awakening at the selected pressure. Still, you have adequate titration if you're not able to reduce the RDI less than 10, but you could reduce the RDI less than by 75%. Those for severe obstructive sleep apnea. So if you have patients who have RDI of 100 or 130, which we see them, if you achieved reducing that by 75%, this is still adequate ventilation. Or if you adequate PAP titration. If you, or the other criteria to call it adequate titration, if you have the criteria from 1 or 2, reducing RDI by less than 5 or less than 10, but you don't have the REM sleep. So you eliminated those events only in non-REM sleep or in lateral position, you still call this adequate. Unacceptable titration, who doesn't meet any of that? In that case, you need to repeat your PAP titration, or you need to look for something else. So that's everything went smooth, and you got the pressure that you needed for your patients. Of course, that's not the daily life, and there are multiple difficulties and challenges that we face during the PAP titration. And I'm going to try to outline some of those, try to see how we can deal with them and solve them, and based on the data and based on the other expert opinions as well. So the first challenge we may face is the patient won't sleep. Insomnia during day 1, this is either first night effect, or the patient is nervous or having any other issues, but you put your CPAP mask and your patient won't sleep. What we do? Try to calm him down, try to reassure him, but I mean, should we use hypnotics? Hypnotics were tried, and there's like a lot of data. We don't have usually a lot of data on sleep, but there's like a good amount of data and studies about using hypnotics for PAP titrations. And isobuclone, which is the non-benzos hypnotics that we use. This is a long-acting non-benzo hypnotics. I think it's a half-life of like 6 hours. These studies were done like, this was like a prospective randomized placebo-controlled trial. They give the patient hypnotic right before starting the CPAP titrations. The study population was like 226. There was like 113 in each arm, and they checked. They gave the patients either Lunesta or isobuclone, 3 milligrams before the study versus a placebo that looks the same. And they measured the sleep latency, sleep efficiency, total sleep time, wakefulness after sleep onset, and how the rate of inadequate PAP titrations. And they defined that if you have if the patient sleep with PAP of less than 2 hours or 120 minutes of sleep, or if you have an inadequate or incomplete titration, that means you have higher RDI than 5 or 10. And they found that isobuclone improved sleep latency, sleep efficiency, total sleep time, and also reduced the WASO, or walk after sleep onset. It also improved the quality of the titration studies. So patients slept longer on CPAP. They needed less pressure to titrate to get to a better RDI faster as well, and the quality of sleep were better on the hypnotics. If you look at these, we have to be careful with that, because if you look at the patient characteristics, and these are mostly relatively younger patients, so the age was like 44, 45 plus minus like 10 years. So we usually have we should be careful about that. These patients, they ruled out patients with congestive heart failure with significant like comorbidities, patients who are on like narcotics and pain medications. So we have to be careful in using those medications when we set up. But I mean, for people who received the hypnotic, the isobuclone or the Lunesta, they did really better than the other for the quality of sleep studies and for finding the good CPAP for them. The side effects were about the same on both groups, and the investigators concluded that the pretreatment with the azabiclone improves the quality of polysomnography, and CPAP titration decreases the need for repeat studies. There is another study who looked for different outcome, about the same. It's called, so this was published in Chest in 2009. And they did the same, but they were looking for the CPAP compliance after a month of trial. And they found the same thing. And the same finding is it obviously improves the sleep latency, improved the sleep efficiency, and the quality of sleep. But what's more important, they found that there's significantly improvement in the CPAP compliance of those patients who started on the azabiclone after a month of treatment. So I put a question mark on hypnotics to start with because there are negative studies too. This study used the azabiclone, which is a shorter-acting non-benzos hypnotic, and this study they were trying to find out if there's any improvement in the CPAP compliance using this azabiclone. The half-life of this medication is like an hour versus like almost 6 hours on the Unistat. This is Sonata. And the study was used a split night sleep study instead of like a CPAP titration. So I know split night has a lot of interruptions, and the duration of the treatment is shorter too. But this study was negative to show any difference between the people who received single dose of azabiclone versus placebo. In our lab, we have a hypnotic protocol for younger patients that the technician can go with that. If the patient younger doesn't have any significant comorbidity, they're not already on hypnotics or benzos. And for older patients, and I'm always on call for those to try to judge the risk versus the benefit. If the patient won't sleep and he is 65 or older, you need to talk to your on-call doctor and come up with the recommendations about should we do it, should we not. You need to make sure that you have at least 7 hours of sleep before. The patient needs to have a ride next day, and all of that for the patient's safety. So this is number one, insomnia. The second problem you may face when you do titration is significant leak. And leak can be challenging too. Different anatomy and different mask, and the patient, they don't like to have like the straps really fit on them. We have two types of leak in general. We have intentional leak, which is the leak was made to allow the air to go out and prevent the rebreathing. So there's like a controlled leak or intentional leak in the mask. Small leak allows the CO2 to go out and you don't have to rebreathe it. Or you could call it physiological leak. The pathological or unintentional leak, the leak that we don't like, is two types. There's a mouth leak. When you use a nasal mask and your patient don't use the chin strap, it will open the mouth and the leak start coming, the air, the forced air, the pressured air start coming from the mouth. That's called a mouth leak. There's a mask leak, which is related to how you fit the mask on the face. So leak will be the pressure air will come out between the face and the mask itself. How you fix those? For a mouth leak, obviously you put a chin strap around it so the patient will keep his mouth closed during the nasal mask. Just put in mind that when you use the nasal mask, the higher pressure causing significant leak. Anyway, if it is not through them, so nasal mask, especially nasal pillows, you'll face some problems when you do nasal pillows when your patients are requiring like a higher pressure. Mask refit or readjustment, that's used for the mask leak. So try to fit your patient to the best mask possible needed for that. And there's some data about if you improve the mask leak, the oxygenation will improve and the arousal index will be better, and also increase in the REM sleep in those patients. And you need REM sleep to achieve the optimal titration. The third problem you may face is hypoxia. So if you have the patient, usually sometimes we send patients to the sleep lab coming from the hospital. These patients usually admitted for other things, have other problems. They're usually hypoxic baseline. So what do you do if your patient is hypoxic? You give them oxygen. But I mean, how you give oxygen, how you do it is also so. If your patient, if you started the study and you have a patient who is awake and hypoxic, he has oxygen saturation less than 80%, that's an indication of oxygen use. Sometimes your patient is borderline, you think that eliminating the respiratory events or the obstructive events will improve his oxygenation, but you do improve the obstructive events, but your patient's still hypoxic, then in that case, you start them on oxygen if their oxygen saturation is less than 88% for at least 5 minutes. And how you do that, you start oxygen by 1 liter. Your goal is to achieve the oxygen saturation of 88 to 94% between your PAP machine and your oxygen supplementations at night. So whoever hypoxic before the PAP titration, you give them oxygen to reach to 88%. After sleep, you make sure you eliminate the obstructive events because that itself can improve the oxygenation. If you still have problems with that, despite elimination of the respiratory events, you start the oxygen supplementation. You start at 1 liter and go up. Your goal is not to over-oxygenate, but your range is between 88% and 94%. Here's the bigger subject and maybe the most complicated problems on PAP titrations. Sometimes it makes it very difficult to achieve PAP titrations. Is the treatment emergent central sleep apneas. So this happens on average, based on the studies, between 5 to 15% of patients who have sleep apneas that undergo PAP titrations. However, the good news about this is like more than 50%, if they continue to use their CPAP or their PAP machine, these sleep apneas tends to go away spontaneously. But sometimes you're going to lose compliance. You're not going to be comfortable doing that, so you're going to need to do something about it. In that case, you're going to need to change the ventilation way. There are factors that were associated with increase the likelihood of treatment emergent central sleep apneas. There are small studies showing different factors. So male gender is number 1, older age, comorbid congestive heart failure or coronary artery diseases or chronic heart diseases in general, or chronic cardiac problems. Severe obstructive sleep apneas, we'll talk about why. These patients usually have a high loop gain and usually require higher PAP pressures, and this tends to have a more treatment emergent central sleep apneas. If you have a mixture of obstructive apneas, central apneas, or if you have a patient who have a little bit of central apneas, when you do the baseline polysomnography, these patients tend to have a tendency to develop central or complex sleep apneas. Higher arousal index, if the patients there are some patients, they wake up for unexplained reasons. If they have higher arousal index, arousal acts as a stimulus for breathing, and you wash out the CO2, and that will get your CO2 to subthreshold to apneic threshold, and that will have a central apneas, and it will be a vicious circle. So if you have your patient wakes up multiple times, he's a higher risk of developing central sleep apneas. Again, using higher CPAP levels, that can can predispose patients to develop central sleep apnea. So that's why carefully go up, slowly up, down. And if you start seeing centrals, you may need to try a lower pressure than higher pressure. Using bi-level PAP, higher pressure support level. So if you have like a high bi-level PAP or BiPAP in S mode, that also can cause your patient to have to develop central sleep apneas on pressure support. The delta pressure is also very important. The high pressure support is very important. The higher the pressure support, the more risk that your patient will develop central sleep apneas. High altitude because of hypoxia. So if you're or breathing, of course, opioid use also can cause that. Supine sleep positions also. If your patient have centrals, you may try lateral positions and see. Again, elevated nasal resistance, which we had a nice talk on this morning, can cause CPAP intolerance. How this treatment emergent central sleep apneas develop? there are multiple mechanisms. There's something called lobe gain, which is the ratio between the corrective ventilatory support to the disturbance. So you have the disturbance, which is either arousals or hypoxia, then the body, the patient try to correct for that, but there's overcorrection causing. So if you have arousals, overbreathing cause wash out the CO2 to a subthreshold level for centrals, and the patient will have a central episode, and that will accumulate some CO2, and again, that will cause your patient to have a on and off hyperbreathing centrals based on that. That's good a lobe gain. Usually, patients who have severe obstructive sleep apneas, they have a higher lobe gain, and their ventilatory support are usually unstable for that. So once you open up their airways, they start breathing fast, they lower the CO2, then they have a vicious circle of what they call lobe gain. I mean, the hypercapnias centrals, hypercapnias centrals. Positive airway pressure, and that's what we meant to do, is positive airway pressures wash out the CO2. So we need the CO2 for our chemoreceptors to respond, to ventilate. And positive airway pressure, guess what? You open your airways, you wash out the CO2, and that causes central sleep apneas to happen. And again, the vicious circle. Intermittent hypoxias can act as a stimulus for central sleep apneas as well. Either acute or chronic hypoxias increase the sensitivity of the chemoreceptors. And with time, I mean, treatment with nasal CPAP, 3 months was found in some study that is associated with decreased chemoreflex sensitivities and decreased the propensity to develop central sleep apneas. This also explains how sleep apneas, how these complex or treatment emergent central sleep apneas resolve with time. So with time, the sensitivities of these receptors adapt, and the central sleep apneas will be better. Air leak also wash out the CO2. Remember when we said intentional air leak? Air leak meant to wash, not to have us to rebreathe our CO2. If you have too much air leak, that means you wash out the CO2 more. You need that CO2 to breathe as well, so that causes you to have some centrals. So if you have now we mentioned some few things that you could do at the night of titration that can help. Position of the patient. If you see centrals for the patient supine, you might try to get him to be in a lateral position. If you have a higher pressure on your CPAP or PAP, the high delta pressure, you lower that, you lower your pressure down. If you have significant air leak from the mask leak, you try to fix that. Again, the stretch, these all mechanisms, stretch receptors can cause the patient activations, also from the pressure can cause the patient to have hyperopneas and centrals. Other factors like you wake and stimulus during sleep, wakefulness stimulus during sleep. If you have baseline hypopneas, these patients usually congestive heart failure patients, they tend to be tachypnic, they have a lower CO2, and once you correct them, they develop central sleep apneas. There's some patients who are on opioids baseline, they have a reduced ventilatory drive as well, and hypoxia as we mentioned. How you diagnose this? Diagnostic criteria for complex, or in the past we call it complex, now we call it treatment emergent central sleep apneas, according to the 3rd edition of International Classifications of Sleep Disorders, ICSD-3. You need all the criteria met, and you need the patients who already confirmed to have obstructive sleep apneas based on either portable or home sleep studies or polysomnography that show that your patient have at least RDI or AHI of more than 5 or 5 or more of obstructive events. And the second requirement that when you do PAP titrations, you eliminate all the obstructive events, but the central events start to appear. And sometimes we see central events, but these central events has to meet the following criteria. I mean, the central apneas and hypopneas index has to be 5 or higher. And the number of central apneas and hypopneas has to be more than 50% of the obstructive apneas. Because sometimes what happens is while you're titrating the PAP, you start seeing the centrals. And you start seeing there's still obstruction, there's like mixed apnea, still obstructive apneas, there's still central apneas. You call this treatment emergent central sleep apneas when you have more than 50% of the events as central events between like hypopneas and apneas. And this is very important because we cannot, based on when we see the data from the study, it will be just mentioned hypopneas. We don't know if this is hypopnea, like a central hypopneas. Is this like obstructive hypopneas? We have to go back and look at the study. If there is snoring, if like alteration of the flow, we know this central hypopneas. So you need, so the criteria is as following. You need somebody who's diagnosed and confirmed to have obstructive sleep apneas, and the patient start to have centrals when you try to correct those obstructive apneas, and the centrals. The central apneas or hypopneas are apneas and hypopneas index more than 5, and the number of events of centrals is more than 50% of the events total. And the patient has to be symptomatic from that, either sleepiness or have difficulty initiating or maintaining awake during sleepy during the daytime, and if he wakes up with shortness of breath or if he have witnessed apneas. And of course, this central sleep apneas is not explained by other apneas like central sleep apnea, which shows Stokes breathing. So what's the natural history of the treatment emergent central sleep apnea? As we mentioned, observational studies showed that 50 to 85% of patients who retain for who have initially developed central sleep apneas but continue to use the CPAP, these central apneas tend to resolve. However, there's a portion of patients that they may have other issues, those are at higher risk of early CPAP or PAP terminations because of symptoms. They don't feel okay, they don't feel better, they're usually complaining about it, so they're going to stop using CPAP. And there's some data about increased the perioperative, postoperative complications or hospitalizations for those patients as well. How we treat that? We have some data about again, as we mentioned, expectant management with CPAP. So if your patients are not significantly symptomatic and not at high risk of gonna stop using the CPAP, you may just wait and see, explain to your patient this is gonna likely go away after time, especially if you're those patients who they don't have risk factors. So I don't expect that someone who is on narcotics or opioids to resolve his centrals would just wait and see. Those patients who have a congestive heart failure, I also don't expect them to resolve their symptoms. So for somebody who's having a high obstructive sleep apnea and he came to you with CPAP of with AHI of 100 or more than that, and you were able to lower it to 20, but most of those are centrals, those you may give them some time and just reassure them that this is going to be still okay. And usually those patients feel better. They feel better using the CPAP than we're not using the CPAP. So that gives you some time to wait and see. So this study was published in the Sleep Journal in 2014. They compared patients, they just between starting the intervention right away. So the baseline mean AHI for this patient here. I don't know if I can. Mean AHI, usually severe obstructive sleep apneas are around more than 35 per hour. And when they titrate them to CPAP, the black bar here is the central events or central apnea index. And they have developed the central sleep apneas that they compared them. They said they titrated them with ASV right away and they followed them after 90 days. The other group was called CPAP group on the right side. They tried ASV titration initially, and they continued with the CPAP after that. 90 days, the CPAP, you see the improvement. They were able to achieve the less than 5 for a significant amount of patients, comparable to ASV. Definitely ASV is more efficient, but still. This is comparison between ASV and CPAP at 90 days for the same study. And ASV, after 90 days, were able to reach out the around 90% of patients to achieve AHI of less than 10, and around a little bit above 60% of patients who were on CPAP, they were achieved of the AHI less than 5, which is a good number still. AHI less than 5, still after that, the AHI for CPAP, after a while, less than 5 is still a comparable number. So ASV is a better, more efficient, but waiting on CPAP also can be as comparable in some patients. So if you choose to intervene, so that's expectant management, but if you choose to intervene based on the patient's symptoms, based on the patient risk, and if you think your patient won't do better, I mean, he's on opioids and he's on have congestive heart failure, that's not EF not less than 45%. You can try either one of these modalities, either BiPAP with backup rate. Again, it's called BiPAP ST. So this BiPAP will allow the patient to breathe, and once the time lapsed that the patient will take a breath, the machine will give him the breath. So this is like a backup rate for that. Adaptive servoventilation is the maybe best in those, but I mean the cost and other things involves too. This is a comparable study between the BiPAP with backup rate and ASV. I mean the first, I'm sorry if it is not like very clear here, but apnea-hypopnea index initially, so this study they did the initial AHI, then they selected the patient who developed, so this is the initial AHI patient, so apnea-hypopnea index, then the central apnea index, and they selected the patient who developed treatment emergent central sleep apneas, and they followed them after 6 weeks, and those patients selected of the persistent central sleep apneas after that. And they compared using CPAP versus ASV. So patients have a centrals, continued CPAP, comes after 6 weeks, they're still having centrals, so this is persistent central sleep apneas. And they tried BiPAP and ASV. ASV was more efficient in that, basically. The other thing for ASV, I mean, even if there is a small risk of recurrence of central sleep apneas with BiPAP with backup rate versus ASV. So ASV was better so if you see the last, ASV was better about the emergence of central sleep apneas than BiPAP with backup rate. If we're going to talk about the ASV, we need to make sure that if you're going to start your patient on ASV, we need to make sure that have a recent echocardiogram that his EF is more than 45%. It's not even 45%, still goes to the involved in the study that showed increased risk. This study that was in your England Journal of Medicine is a famous study that showed around 6% increase in mortality of all-cause mortality or cardiac mortality related to those patients who have symptomatic congestive heart failure who have mostly central sleep apneas if you use ASV on them. So before you start your ASV, you need to make sure that your patients have an EF, recent echo showing EF of more than 45%. Other treatment options, so we were talking about the treatment of treatment emergent central sleep apneas. We said we wait and see for those patients who are symptomatic and have a lower risk and likely going to resolve up to like 6 weeks to sometimes 90 days. The second option is for those patients who have high risk or for those who we think they're not going to improve, those who are on opioids or have a congestive heart failure or heart disease. You can use either BiPAP with backup rate versus ASV. The third option that you may have, and this is usually like based on resources. So I went back home one time for a visit, and I saw at least 2 patients who have problems with Cheyne-Stokes breathing, and they don't have the resources to do ASV. There is no ASV, although their EF was a little bit higher, and there was a clear their relative were talking about when they sleep, they become like breathing fast or tachypneic, and they pause. Clearly, I mean, you don't even need a sleep study for that. And I recommended them to have just an oxygen, because some studies showing oxygen that helps, and they come after a few weeks and they were grateful and they felt better. So this study was published in 2006 as well, a small number of patients, 25 in each lead, and they compared, so this is for patients who have central sleep apnea due to heart failure, and they tried them on oxygen. The oxygen desaturation index improved significantly, obviously, and the AHI improved significantly after 12 weeks of oxygen use. So oxygen sometimes helps, but we still don't have I don't think we could yet do it in our daily practice. But during my fellowship, we were doing it, and we have some success in that. Modes to avoid, I mean, using PAP is in patient with central or treatment emergent central sleep apneas. I wouldn't say contraindicated, but usually they increases the risk of having the centrals, as it was seen in some studies. So we have it's going to be fast because of time. This is a challenge we face in the hospital about, me as a pulmonologist and most of whoever works in the hospital, it's our challenge for patients who have acute on chronic hypoxic, hypercapnic, or hypercapnic respiratory failure. These patients, either they have severe COPD, or they have obesity hypoventilation, or they have like a severe thoracic restrictive disease, and they come to the hospital like hypercapnic, and you can't find them, you can't have them qualify to have the right machine for them to go home with so they can be discharged. We have patients that stay weeks in the hospital trying to get a machine like that. So acute and chronic hypercapnic respiratory failure characterized by acutely elevated CO2. These patients usually chronic, what we call them a chronic CO2 retainer. They have a higher venous bicarb. And when they come to the hospital, either they have like an infection causing COPD exacerbation, or any events causing the acute exacerbation or acute CO2 retention. So there is a very restricted criteria about some, so that you can have their insurance to provide them the machines possible. I'm just going to skip to this because this is, so for those patients, if you have the best and the easiest maybe to get patients to qualify, if your patient have restrictive thoracic disease, if they have kyphoscoliosis, if they have any restriction causing like a neuromuscular diseases, you just need one of these criteria. Either your patient have a CO2 of equal to more than 45 millimeter mercury, or if your patient is basically not oxygenating. If the oxygen saturation is less than 88% for more than 5 minutes, you still can qualify them to PAP. In spontaneous mode, they could be qualified for a home ventilator too. For those patients who has risk for obesity hypoventilation syndrome, I mean, they have a high BMI, their venous bicarb is like high. These patients, they qualify for PAP or machine if they have a wake ABG, show the PCO2 of more than 45 millimeter mercury, with the breathing regular, I mean, either room air or whatever oxygen you provide them, and you need to prove that they have a hypoventilation during sleep, And with the ABG, either you wake them up and do an ABG, or early in the morning and they saw that they're hyperventilating during sleep. For the most difficult ones is the severe COPD patients that you can get them to, what's difficult about it, you have to rule out the sleep apnea, which is difficult sometimes to perform sleep study inside the hospital. You can't get the patient discharged to go to the sleep lab. So you're stuck there. You have to make sure that your patient have it. They need sleep apnea to be ruled out. Sometimes if your patients are lower risk, usually COPD or have severe COPD patients, they have usually they're 10, they have a low risk for sleep apneas, and you can try to convince the insurance about that. Otherwise, you're going to stuck until your patients have a sleep apnea. Sometimes you send them to a facility who can do the machine until they come back to the sleep lab to do the sleep study. I'm sorry for being out of time. And that's what I have, and thank you very much. Thank you.